back to the cows here. We've just diagnosed this Downer cow, and we'll go on to our next case. And you've seen part of this before. This is a 5-year-old cow that has the sort of obvious diagnosis here. We have a severe hypocalcemia and hypophosphatemia, and that clinically she freshened yesterday, and she's down. So what have we diagnosed here already? Yeah, sure. She's got milk fever, parturient paresis. And if we look at her muscle enzymes, what have we learned? Well, we see here that her CK is high at 1481, and her AST is just coming out of the normal range. So what does this tell us about the muscle necrosis in this cow? It's recent, right. So her AST is barely coming up. We can't really give any kind of prognostic information on this. This is current muscle necrosis of certainly less than 96 hours in duration, probably less than that, where we're barely getting an elevation in AST. So it fits the clinical picture. She just freshened yesterday. She's only been down for, say, 24 hours or so. So this fits the picture perfectly. And she was treated and she recovered. So it just shows you that even despite this severe hypocalcemia, we can get total recovery. So it is not helpful prognostically, the level of severity of hypocalcemia. And what about this condition of parturient paresis? Well, it's not all that unusual. It's usually seen in animals in the third, fourth, fifth, sixth lactation, perhaps, and has been artificially divided into several stages from a clinical standpoint that has been somewhat associated with certain values of calcium. The so-called first stage is manifest by hypersensitivity, excitation, tremors, and ataxia, and is not the stage at which veterinarians are usually examining these animals, and that has been associated with calcium values of around 5 to 7. The second stage is the stage in which we sort of classically think of as the cow with milk fever, where she's in sternal recumbency and has her head tucked into her flank. They usually have cold ears, are anorectic, and may have dilated pupils as well. And this is sort of the real commonly seen case of parturient paresis, where we have values of 3 to 6 or so for calcium. And then, as you see, it progresses to a stage of coma with muscle flaccidity and inability to even maintain sternal recumbency. These animals are in dire straits, and of course, if left untreated, will die. These animals will have calciums of 2 or less. It is not unusual to be reviewing biochemical profiles in cows, though, and see, I would say, I think I frequently see them of 3 or less. In terms of the animals that are being selected for blood work to be drawn. The usual clinical circumstance is that the veterinarian is seeing the animal, taking the blood, giving the calcium, because obviously that has to be given right away, and then using the biochemical profile as, number one, to confirm the diagnosis, but also to see if there's any other problem occurring in the animal. And so they'll be referring to it later. They'll be treating the cows, of course, right away. So if we go back and look at this particular animal, we see that this animal should have been in the stage of where she was almost comatose. She really wasn't as bad off clinically as this would suggest, and she did recover totally. Now, in the literature, it is suggested that the hypocalcemia of parturient paresis is associated with hypophosphatemia and normal to increased levels of magnesium. And I find that, at least in the profiles that I see from cows, that's a little hard to find. Here's an example of a cow that is clearly hypocalcemic. This one does not have a low phosphorus. This cow hasn't been down very long. Her CK is normal and her AST is normal. So it's unusual to see one like that too. But she does have a high magnesium. And I searched high and low really to find one of our milk fever cases that actually had a high magnesium. But this one has a high magnesium. But I show that only to illustrate that the books say that they should be hypocalcemic and hypermagnesiemic, but it's not frequently the case. It's more frequent to find them like this with hypocalcemia. Again, there's another one whose enzymes aren't particularly elevated. It's in the Midwest. It actually has more shape to it. There are some other states, some of which you will become familiar with, that are more rhomboid. And within Wisconsin, Marshfield is smack in the middle of it's called the city in the center. There's a little city nearby called Pittsville, with a name like Pittsville, you know, that they're in trouble already, but they claim to be the exact center of the state. But Marshfield calls itself the city in the center. And it's, as you see, in the middle of Wisconsin, and Madison is down here, and Milwaukee is somewhere down here. But where are we? Well, so this is supposed to do it, huh? Okay. We're right in the middle of the biggest dairy country in the U.S. still, even though California is getting more and more milk production. But Marshfield is right in the middle of rural dairy country in Wisconsin. And the Marshfield Clinic is in the middle of this area. So it's kind of an unusual tertiary care medical facility with a reference laboratory for physicians and veterinarians, and that's where we come in. We do see specimens from all over the state of Wisconsin and northern Illinois and the Twin Cities area. So today my focus is going to be on the kinds of animal specimens that we see, which include small animals and dairy cows. An interesting mixture. And the entire presentation today will be on a case basis. So we're going to discuss these cases as if you were the practitioner seeing the case. I'm going to give you only selected laboratory findings to make the points, and it's going to be totally clinically oriented. This first case is a 3-month-old Great Dane with these laboratory findings, and I'll tell you that the AST, ALT liver enzymes are normal, as is the ALP. And I want to focus in on the serum urea nitrogen and creatinine values. And right away, I think you will notice that these values are high. So we would say this animal is azotemic. Now, what's peculiar about this? What is particularly peculiar about this relationship between urea nitrogen and creatinine? It's not proportionate, is it? This creatinine is barely out of the normal range. 1.92, something like that, is going to be normal. And this urea nitrogen is very high. So when we're talking about urea nitrogen and creatinine in terms of renal function, they are both measures of glomerular filtration rate. When you see a disproportionate rise in BUN relative to creatinine, then we know that the explanation cannot be GFR alone, because if it were, they'd rise together. So there's got to be an explanation, a non-renal explanation, as to why the urea nitrogen is higher disproportionately to the creatinine. And the reason would be, one of the reasons for a non-renal influence on this analyte. And what are the common ones? Well, in small animals, hemorrhage in the small intestine, or hemorrhage in the intestine, is the most common. By far and away, most of the cases are going to be the result of hemorrhage in the intestine. And then from a theoretical standpoint, fever and burns can do it too, but that is not generally the reason for a rise in BUN. And what is the mechanism? Well, you have hemorrhage in the intestine, you have a greater protein delivery to the small intestine, and it's a source for ammonia, which goes to the liver and is made into urea. So that would be a reason the creatinine would not be going up, but the BUN would be. Now, there are reasons for decreased BUN that have nothing to do with GFR, and these are quite common too. Anorexia is the most common. A study was done some years ago and showed that 3 days of total anorexia can statistically lower the BUN in a dog or a cat. So if you just take away the food for 3 days, the BUN will become statistically lower than normal. I'm not saying it's out of the normal range. I'm just saying that it shows that feed intake has directly related to urea nitrogen. Severe hepatic insufficiency is often associated with a low urea nitrogen, and that's because of the inability of the liver to make urea. And the most common cause of that would be a portal cable shunt, so decreased liver mass. And then this is, again, one of those theoretical reasons. I don't know if we've ever proven that anabolic steroids could also decrease the BUN. Now, there are some very uncommon non-renal influences on creatinine. And most of these I have never seen myself or been able to associate an increased creatinine with anything other than increased GFR. They say that muscle necrosis can increase creatinine, but we have very good examples of that in downer cows, say, and their creatinine is not increased. So, I mean, yeah, I've read that too, but I've never seen it. The same goes for strenuous exercise. It's said to increase the creatinine, but again, it's something that must not be clinically very relevant because it's very difficult to pick that out. And then there's some very vague references to a dietary influence increasing creatinine, but again, very poorly documented. Decreased creatinine may be associated with muscle wasting, and that is something you will see clinically. And if you notice, if you ever look at reference ranges for normal creatinine in humans, for instance, there are different ranges for children and women and men, and that reflects variations in muscle mass, normal muscle mass. And when we think about, say, dogs, for instance, we always think there's a dog reference range, you know, as if a dog is a dog is a dog, as if a Chihuahua has the same muscle mass as a Great Dane or a Greyhound. And yet, it probably is our problem in general with not getting, you know, really, really good reference ranges in animals, such that our reference range probably encompasses the very, very small dog to the very, very big dog, and therefore it is too wide to detect some of these changes in creatinine. So that we're saying, it's in the reference range, therefore there has been no effect. But indeed, you will sometimes see very low creatinines in small dogs, say a poodle or a Chihuahua, particularly if they're emaciated, or you can see a very low creatinine in a cat that's emaciated that may very well be this source here. So if we go back to our case now, our 3-month-old Great Dane with the disproportionate increase in urea nitrogen relative to creatinine, so what is the likely cause going to be? These are all games of percentages, anatomic and clinical pathology. You have to learn what all the causes are, but then it's a percentage game to show your experience, to show that yes, indeed. Yeah, it could be all these things, but what is it really? I mean, what's a 90% chance? What would you tell the owner? What would you say? And in this case, what is the likely cause then of this high urea nitrogen relative to creatinine? Hemorrhage in the gut. And indeed, this animal had hemorrhagic diarrhea. That was the cause here, and it shows the percentage play. That's going to be what it is. Let's look at another case example of this disproportionate relationship, and here it's the opposite direction. The urea nitrogen is low and the creatinine is high, and this is in a 13-year-old cat. Real common. See this all the time. And yet you'll see practitioners that say, I've never seen it before. Well, all you got to do is look, because it's there. And you know, people have been practicing 20 years, I've never seen this. Well, oh my God, you can see it every week on a profile, if you look at a series of profiles. Well, here remember we say that increases in creatinine are not real common. In other words, non-renal influences on creatinine are real uncommon. You know, like that, remember I said muscle necrosis, strenuous exercise, I haven't seen it. So we have to believe, percentage play, that this creatinine increase is a GFR influence. And then if that's the case, if it's decreased GFR, glomerular filtration rate, then this urea nitrogen is too low. And if that's the case, then we just have to go through our list of rule-outs as, well, why is the urea nitrogen too low? Well, what would they be then? Most of these are not real uncommon. Anorexia, yeah, you see it all the time. It's a sick cat with either pre-renal or renal azotemia, and it just hasn't been eating. See it all the time. Okay, here's another case. This is an 8-year-old male Labrador Retriever that I'm purposely keeping the clinical history from you for a point. And we see these laboratory findings. And we see a urea nitrogen creatinine relationship here. And what's proportionate? Someone often asks that. So what's that mean, proportionate? Well, there's some really not set guidelines, but the normal relationship between urea nitrogen and creatinine when they rise in relationship to GFR is about 20 to 30 times urea nitrogen versus creatinine. And this one's about right, looks a little bit high. So what we've decided here with this dog is that it's azotemic. So then the big question becomes, is this pre-renal, in other words, a decreased GFR due to blood flow, or is this renal azotemia? And how in the heck do we find out? Well, there's some rules. And the values for BUN, creatinine, and phosphorus, this is phosphorus, overlap in azotemia of any cause. And I've heard practitioners say that, oh, that phosphorus was really high. Well, it's just a measure of GFR like BUN and creatinine are. It isn't any more specific at telling the cause of that azotemia than are BUN and creatinine. And so therefore, using a BUN-creatinine relationship, which is sometimes taught, is really not useful because the BUN-creatinine relationship is similar if animals with similar extent of azotemia are compared. So that it's more related to the extent or severity of the azotemia than it is the cause. So what we have here is one rule. The urine should be maximally concentrated if the cause of azotemia is pre-renal. The reason being is basically the animal is doing an endogenous creatinine clearance test to itself, and so it should be able to come up with this, that azotemia and low urine-specific gravity should equal renal disease. So the animal is maximally doing a concentration test by decreasing its own GFR, and if it can't concentrate, then that should mean there's something wrong with its kidney. So let's look at here. This is our 8-year-old male Labrador, and we have azotemia, as we saw before, and the urine-specific gravity is 1045, and that's maximally concentrated for a dog. Cats, we generally use 1040 as the cutoff, and cats can concentrate up to 1060 or so, but we still count them as maximally concentrated at 1040. And this is so this dog has azotemia and a concentrated urine. This doesn't necessarily mean that he has pre-renal azotemia, but it sure points to that. In other words, we have no evidence that this animal has renal azotemia. He is concentrating and he is azotemic. And sure enough, this dog has a dog with congestive heart failure. And this is just azotemia relating to congestive heart failure, decreased GFR, and the urine-specific gravity reflects that. Here's a 1.5-year-old Cocker Spaniel, laboratory values from that dog. And what we see in this is that this dog is azotemic. The phosphorus is high, calcium is high, sodium is low, potassium is high, chloride is okay, and the albumin is okay. And I want to concentrate here on the azotemia, including the measures of GFR, BUN, creatinine, and phosphorus. And we have some more laboratory work. His specific gravity is 1011, and his pH is 5. He's a slight proteinuria and has no significant sediment. So what is our conclusion? Well, it should mean that this animal has renal disease, shouldn't it? But we have some more laboratory work, and this dog also has did an ACTH stim. We have a very astute clinician here, and we have a pre-ACTH stim cortisol of less than 0.5, which is low, and we have a post-ACTH stim of cortisol of less than 5. In other words, this dog won't stim at all. So what is the diagnosis? So this dog has Addison's disease or hypoadrenocorticism, but he broke the rule, didn't he? So there are exceptions. To every good rule, there are exceptions. And it's useful to know these exceptions, number one, because they lead you to the diagnosis. The other thing is, when you have a rule, most things go by the rule, but there are some unique exceptions to this rule, and if you know what the exceptions are, you'll get to that diagnosis a lot more quickly than probably using other criteria. So the first exception to the rule of azotemia and low specific gravity, meaning renal disease, is what this dog has. This dog has hypoadrenocorticism. There are other exceptions as well, what we call medullary washout, hyponatremia, blood loss, and when the animal has two concurrent problems, one that produces pre-renal azotemia and one that produces a low urine-specific gravity. And we'll go through these so you can see the mechanism. In hypoadrenocorticism, the dogs excrete a low urine with low specific gravity when they're dehydrated, hypotensive, and hyponatremic. And the reason that they have this low specific gravity is they have a period in which they excrete lots of sodium in their urine. Consequently, they have solute diuresis. They decrease their renal medullary interstitial osmolality and consequently have difficulty concentrating their urine. And if you don't remember that very well about how that works, I thought I'd review it here for a moment. The ability of the kidney to concentrate the urine is dependent on several factors. One is a maintenance of the interstitial osmolality at a high level. This is the interstitium, and we'll talk about its relationship in a moment. The other is maintaining normal blood flow through the vasa recta, which are here, and maintaining normal urine flow, and having a functioning antidiuretic hormone system. So what happens when this is the renal tubular fluid, it is basically a filtrate of blood, and it is isosmotic as the urine filtrate goes to the medulla. And as we get into the medulla, the descending loop of Henle is permeable to water. The water comes out because the medulla is very hypertonic. And you would think that would dilute out the medulla, but it doesn't, because the vasa recta, as fast as that water comes out, carries that water away. And so we are increasing the concentration of urine, of filtrate rather, as we move towards the medulla. Then we make this hairpin turn and come up the ascending limb, which as you see is thick here and impermeable to water, but permeable to sodium, is actively pumped out into the interstitium, increasing the interstitial osmolality because of the addition of sodium. So now actually the urine is becoming more dilute. So it's becoming more dilute as we come up this way. And then under the influence of aldosterone in the distal tubules, we have a sodium exchange for potassium, which doesn't really influence the osmolality too much. The biggest influence on the urine-specific gravity is the effect of antidiuretic hormone in the collecting ducts. And depending on whether antidiuretic hormone is present or absent, depends on whether that filtrate, as it goes back down through the high osmolality of the medulla, whether or not we're going to lose water into the medulla, into the interstitium or not. And if antidiuretic hormone is present, then let's see, if antidiuretic hormone is present, then we will have water retained. And if antidiuretic hormone is absent, then it will be absorbed. Did I say that backwards? And we'll cover this in just a moment anyway, because I will say it backwards ad infinitum. Medullary washout is a decrease in the renal interstitial osmolality due to increased urine flow rate from any cause, or increased blood flow rate from any cause. You can also get a medullary washout with loop diuretics, which is of course how they work, essentially. And so this will decrease the kidney's ability to concentrate the urine. And if that's associated with any cause of prerenal azotemia, then we will have an exception to the rule. And here's another exception. We have an 8-year-old male beagle who was presented at a university for the problem of posterior paresis. The dog also has melena and cervical pain and was eventually diagnosed with a disc herniation. The dog underwent a hemolaminectomy and was treated with fluids. And 2 days following surgery, the animal has these laboratory findings: a low BUN, high BUN, a low sodium, a high potassium, and a urine-specific gravity of 1010. And these clinicians, understanding the rule, said, this dog has renal disease. And after a number of cases were seen with this problem, 9 to be exact, they noted that they had a series of dogs with concurrent hyponatremia, azotemia, and a low urine-specific gravity that was not due to renal disease, but what these dogs had in common was blood loss. And similar biochemical abnormalities were produced in another dog, experimental dog, by phlebotomy and giving the dog a low-sodium diet. So here we have another exception to the rule. We have actually can use 2 exceptions in this. We could say blood loss or hyponatremia was the cause of low urine-specific gravity in relationship to azotemia. And this hyponatremia may come not from just blood loss. It could come from diarrhea or overuse of diuretics, and then the azotemia is the result of fluid loss secondary to the problem, the diarrhea or the diuresis. And the reason the urine is dilute is because 2 reasons. The big reason is probably because the renal medullary interstitium depends on sodium and urea to maintain its hypertonicity. If you have low sodium in the body, it's going to lose the interstitial osmolality, and consequently, no matter what, the kidney is going to lose its ability, temporarily anyway, to concentrate until you replete that interstitial osmolality with sodium and urea. So as a consequence of that, we have a low specific gravity urine. There's a minor effect probably on the sodium on osmoreceptors and decreased ADH release. So finally we come to the final exception, which is really many exceptions, two concurrent problems, one that produces prerenal azotemia and one producing low urine specific gravity. So what would this be? Well, it would be any cause of prerenal azotemia combined with some other problem, like post-obstruction diuresis, diabetes insipidus, too many glucocorticoids, pyometra by a mechanism that's poorly understood. The same with hepatic failure, the mechanism that is also poorly understood. In other words, the mechanism of diuresis. Hypercalcemia and potassium deficiency could all cause the low urine specific gravity in an animal that does not have renal disease. So our next case is actually we have two sets of laboratory work on a 9-month-old Shetland sheepdog. And this dog was presented at an emergency clinic with the first values that you see. This dog came in, collapsed and down, and had been trembling and circling and vomiting prior to its collapse. And we have azotemia and a high calcium. And that was seen at the emergency clinic. And the animal was treated with fluids for the remainder of the evening and then shipped to the regular veterinarian the next day. And you can see that we did a lot of good here. We have a rise in the VUN and creatinine with the addition of fluids. And now we've added a phosphorus here. And we still have a minorly high calcium. So at the regular veterinarians, they did a urine-specific gravity urinalysis, and we see a low specific gravity with 2+ protein and some white cells. So what have we got now? We've got azotemia, a low urine-specific gravity, and proteinuria, and some white cells in the urine. Is this a rule or an exception? Well, we have a vote for an exception. Well, the question is, can you tell? Can you even tell? We have azotemia in either instance, whether it's a rule or an exception. If it was an exception, we better be able to go down our list of exceptions and figure out why. If there's no prior history of polyuria, polydipsia preceding the animal's presentation, then he probably doesn't have a cause of medullary washout, because that should have been clinically in the history. Then we have another thing that's useful to note. This animal actually got fluids overnight and became more azotemic, which is kind of unusual and would probably only happen in the case in which the animal truly had a renal cause of azotemia. Because if it was a pre-renal cause of azotemia and you replete the animal with fluids, you're going to decrease his BUN and creatinine. Now, you could argue they didn't really get the fluids or something happened, but nonetheless, if you think about it, in all of our exceptions, we had a reason for pre-renal azotemia. And either clinically you should be able to detect that the animal is collapsed, has a decreased capillary refill, has some problem. It may be very subtle. Or if you give him fluids, you should decrease his prerenal azotemia, which is sort of the whole point. And in this case, we didn't decrease his azotemia. That and the fact that he had proteinuria, which was not present in our exceptions, and he had white cells in the urine, which could be a lower urinary tract sign too. But no, we can't 100% tell, but the percentage play here is because we didn't decrease his azotemia with fluids, because he has proteinuria, because he has white cells in the urine. This dog should have renal disease, and it's only 9 months old. Well, he has familial renal disease, and as you know, there's many breeds of dogs in which familial renal disease has been reported. In fact, there's probably not a breed that would be an exception to the possibility for congenital or at least congenital, if not familial, renal disease. And here I've listed some of the breeds, and we know the familial characteristics in Samoyeds, Dobermans, Norwegian Elkhounds, Chows, and Bernese Mountain Dogs, but we don't know for sure the hereditary characteristics in many of the other breeds. And there are probably other breeds you could add to this list. But no, you can't tell, of course, by the age of the dog whether he's likely to have renal disease. And the question often comes up in cats, for instance. Does it occur in cats? Well, sure. There are some sort of notable exceptions in notable examples in cats. We think about polycystic kidneys and Persians, amyloidosis, and Abyssinians. And in Siamese with porphyria, there is a renal lesion. Also, renal dysplasia, which was what we're talking about here in this Sheltie, certainly occurs in cats, although Its familial nature in many instances is not proven, similar to the situation in dogs. All right. Now, okay. Here we have a 9-year-old cat that has these laboratory abnormalities. A low sodium, a low chloride, and low potassium, not real low, but low, and is azotemic. What's going on here? Is this pre-renal or renal azotemia? And if we did a urine-specific gravity, would we be able to tell? Well, it'd be hard to tell. This cat has a reason to have an exception here, right? This cat could have pre-renal azotemia and a low urine-specific gravity because it's so hyponatremic. I mean, that's a very dramatic hyponatremia. 140 is normal. So we're talking about very extensive electrolyte disturbance here, which could account for a low specific gravity in association with azotemia. So it would be very difficult to tell on the basis of a urine-specific gravity whether or not this animal has renal disease or pre-renal azotemia. So we have to focus in. There aren't too many reasons for low sodiums. And so I like to focus in on the abnormalities that don't have many reasons because you can learn them. They're not very many, so you can remember them in your head or go to a short list and figure out what it could be. And that makes it a lot easier than focusing in on azotemia, which has many causes. Well, what are the causes of hyponatremia? Well, the first we can sort of discount a little bit, but it's always brought up. There's so-called pseudo-hyponatremia. And pseudo-hyponatremia is a laboratory finding. It has nothing to do with the animal, at least in terms of metabolic disease. Pseudo-hyponatremia is when you have an animal that has a high triglyceride level in its serum. So you have an animal with a usually they have a high cholesterol with that, but you have an animal postprandial, say, that has a high level of lipids in the serum, and you're measuring the electrolytes. And when you measure the electrolytes, you're only measuring, they're in water. They're aqueous-based solutes, actually. And when you're measuring, let's just say, for instance, you're talking about the analyzer, let's just say it measured a big volume, like a mil. Well, it doesn't. It measures very small volumes. But let's just say it measured a mil, and say that half of that mil was fat. Well, it's not going to measure anything in that fat. It's only going to measure in the half a mil that's water-based. So the analyzer knows that it takes in a certain amount. Let's just say it takes in a mil. And it's going to measure sodium in only half of that volume. But it's going to put that sodium result over the entire mil because that's how much it took in. So it's a laboratory artifact because of the fact that lipid has displaced the electrolytes to the smaller aqueous portion of the fluid that you get what they call pseudo-hyponatremia. Now, if your laboratory is really doing its job, this should be a kind of a non-entity because the laboratory should be ultracentrifuging that fluid, that serum, to remove the triglycerides so that you're only going to be measuring the aqueous portion. So pseudo-hyponatremia would come from you taking the very high fat postprandial serum sample, putting it right on the analyzer with no manipulation and just saying that sodium that came out of 103, that's what it is. But the laboratory actually should be manipulating that, but in some laboratories they wouldn't manipulate it, nor would they let you know whether or not they had manipulated it. So that's the reason for this so-called pseudo-hyponatremia. The animal may have a totally normal sodium, but the sodium you're getting from the laboratory may be low. It actually influences potassium as well, too. It's possible to do the same sort of exclusion effect with proteins, but the effect is much less. Now, one of the more common causes in terms of percentage plays in which you see in the clinical situation is what they call third space losses or electrolyte loss with water repletion. And this happens very frequently, and we will see examples of this. The animal that has, say, is vomiting or has diarrhea is a real prime example of this. And if you think about, okay, you think about the animal that it's vomiting. Almost all body fluids are isoosmotic or low in sodium in relationship to the serum. So if they're vomiting up something that has less sodium in it than their serum, how in the world do they get hyponatremic? How does that happen? Well, the body senses the fluid loss and stimulates ADH production, and that actually dilutes the sodium in the serum. And we'll go through that in a minute, but it's so commonly a cause of low sodium that it doesn't take very long to find examples of why the sodium would be low in that circumstance. So we have vomiting, diarrhea. A real classic example is ruptured urinary bladder and foals, but is the mechanism exactly the same? Peritonitis and ascites are also causes of what they call third space losses. Hypoadrenocorticism, which we've seen, is a cause of hyponatremia. Hyperglycemia is a cause of hyponatremia. And how does that work? Well, the animals say that it's diabetic. The sodium and glucose are being filtered at the glomerulus. And then because there's so much glucose in the filtrate, the sodium, 80% of which is reabsorbed in the proximal tubules, is not resorbed because of the flow rate in the urine filtrate due to the high glucose. And then for the similar reasons of sodium reabsorption in the proximal tubules, when you have necrosis of the proximal tubules, you get hyponatremic. Now, causes of polydipsia, particularly psychogenic polydipsia, you can actually dilute your sodium level in the serum due to over intake of water. That's very unusual. We talked already about blood loss, and other fluid losses, including cerebrospinal fluid, has been associated with hyponatremia. It's still a third space kind of loss. And the mechanism of that is ADH secretion due to the low blood pressure and the fluid loss. But ADH can also be secreted for no particularly good reason. It's sort of, I always think of it as a garbage can diagnosis of hyponatremia, is what you start thinking about the syndrome of inappropriate ADH secretion when you have a low sodium and you can't figure out why. And you think, oh, it must be that. It's always an out, because there's always some syndrome that you can attribute it to that may cover for your inability to actually make the diagnosis. So that's a nice one to have. But you do actually have to be able to prove that there is no other cause of hyponatremia when you're going to diagnose a syndrome of inappropriate ADH. I've read that alkalosis is associated with hyponatremia, but the exact mechanism or causative nature of that, I think, is nebulous. And certain drugs can induce hyponatremia. Go back to our case. Here's our cat who's severely hyponatremic, and we have one other laboratory finding. So the mechanism of hyponatremia in this cat is, sure, this is a diabetic cat. So this cat is losing tremendous amounts of glucose in the urine because of the high glucose in the serum, and is just pulling sodium into the urine because of that. So that's the mechanism in this animal. Let's take this example, and these are some of my favorite cases. Again, it will be a dog. This is a dog with a unique set of laboratory findings that tells you the diagnosis. We have normal liver enzymes here. Total protein and albumin are slightly elevated. We have azotemia, BUN of 82 and a creatinine 1.9. We have a very low sodium, 113. Combined with a very low potassium and a very high bicarbonate. Total CO2 is bicarbonate. So the unique findings here, azotemia is not unique, but certainly this is a very unique set of laboratory abnormalities. Low sodium, low potassium, high bicarb. Very unique. Very unique in a small animal. But here we have similar findings in a cow. And I think for some reason we have a lot easier time dealing with the rule-outs in a cow than we do in a dog or a cat, because we accept this in a cow, but maybe this comes because we only have 2 diagnoses in a cow, and this is one of them. And in the dog, we have more that we can think of, and therefore we have a harder time figuring out which of the ones is it going to be. So here, let's think about this same findings. We have low sodium, low potassium, low chloride, high bicarb. We'll forget the ketones for a moment, because that's a cow thing. But let's think about this. Okay, so you have to think about cows now. And okay, what happens in cows, and what could this possibly be? I didn't show you calcium, so it's not that calcium thing that happens in cows. So what would this be? Let's see, cow disease. any cow disease. You got a displaced abomasum. Hey, all right. So it's like, okay, so we accept that in it. So why didn't we come up with that in the dog? Well, they don't have an abomasum for one thing, but the mechanism is the same. The mechanism is the same. What is happening in this cow? And we'll go back and look at the dog. Well, the cow is getting a low sodium, low potassium. Well, let's start with low sodium. Low sodium is a third space loss problem. We'll go into that. There's fluid loss, there's ADH secretion, there's dilution of the sodium. And we'll talk about that in just a moment. The low potassium, how come the low potassium? Well, a cow will have two reasons. One is they eat a tremendous amount of potassium every single day. And if they start getting anorectic, they start getting low potassium because the kidney can't compensate for that for about 72 hours. We're going to have to discount this a little bit in the dog because they don't eat near as much potassium as a dairy cow. But there's another mechanism. We have a low chloride and a high bicarb. Now, high bicarbs are pretty common in cows, but that's mainly because they've got abomasum and things like that. But why is the bicarb going up? Why is this animal becoming alkalotic with the displaced abomasum? Well, her abomasum is displaced, and so it's it has something to do with that. And it's because we're sequestering hydrochloric acid in the abomasum, and as a consequence of that, we have bicarb going up in the serum, and the chloride is also being sequestered. So we have bicarb going up, and you know what happens when the animal becomes acidotic? Their hydrogen goes into their cells and their potassium comes out, so they can get hyperkalemic. Well, the opposite can happen with an animal with alkalosis. With an animal with alkalosis, bicarb goes into the cells. So in this cow, we have two mechanisms for hypokalemia. One, the animal is anorectic, and two, the animal is alkalotic. And because they're alkalotic, then they have a reason for potassium to be going into the cells. So we accept that a little bit better, I think, in the cow than we do the Springer Spaniel. But the mechanism is the same. And this is so unusual in a dog that we can diagnose the disease. Like we have these laboratory abnormalities with cows with some frequency. Some of them have displaced abomasum. Some of them just have abomasums that aren't moving. But here in a dog, it's very unusual for a carnivore to become alkalotic. Name another cause of metabolic alkalosis. There are hardly any causes of metabolic alkalosis except this in a dog or a cat. This animal is hypokalemic because it's alkalotic, or that's the main reason. And why? How do you produce this? I mean, they don't have an abomasum in displace. And most of the time when dogs vomit, they're vomiting up duodenal contents as well as stomach contents, so they're not becoming alkalotic. Duodenal contents, they're going to be vomiting up contents high in bicarbs, so they actually don't become that way. So how, I mean, this is not an experimental situation, but if it was, how would you produce this? Say that it's a physiology experiment, and I want to make a dog alkalotic. How am I going to do it? And then how is this going to happen in real life? We've got to have a lesion that's right at the pylorus. I mean, it has to be right at the pylorus, because if it's past the pylorus and we have some sequestration, we're going to be sequestering bicarb as well as acid. And the lesion in this dog right at the pylorus is a rubber ball. And this is virtually diagnostic of an obstruction right at the pylorus. That's about the only thing that can do it. And to show you that it doesn't happen in just one dog, rubber balls are kind of common. And this dog has it too. This dog's got a low, not as dramatic as the other dog. This dog has a low sodium, a low potassium, a low chloride, and a high bicarb. I mean, that is not necessarily a rubber ball. It could be some other foreign body, but rubber ball is what it was in this one too. This animal is also azotemic. You could argue, no, I guess it is proportionate. So the mechanism being the same, that we have to we can account for the low sodium by a dilutional phenomenon, the low potassium by the alkalosis, and we can account for the bicarb and chloride through sequestration of hydrochloric acid in the stomach. Now let's go into this. Since this mechanism with ADH is very, very common, we have to go through the kidney one more time. This time I'll get it right. when we're talking about the influence of ADH on the kidney that induces or is responsible for the concentrating ability of the kidney, it also is responsible for all these abnormalities in which we have the development of a low sodium in the face of loss of fluids that don't contain much sodium in them. If you think about that, it's hard to explain unless you understand this mechanism, because most body fluids are low in sodium. So no matter how much of them you lose, you're not losing enough sodium to account for the animal to have a serum sodium that's low unless you understand this mechanism. And this mechanism happens all the time. And in this, here we have an illustration of the renal medulla and the vasa recta, the loop of Henle, and the distal and tubules and collecting duct. And in this instance, there is no antidiuretic hormone. And what has happened here is the fluid, as it's come down from in the glomerular filtrate down the proximal to the tubules to the loop of Henle, we have become serially more concentrated as the water comes out the descending loop of Henle and becomes more concentrated. We turn the loop, we go back up, and as we go back up, we are pumping some sodium into the interstitium here. And by pumping the sodium into the interstitium, we are actually diluting the urine. So we're going back up into the distal tubules, and we do have a sodium-potassium exchange in the distal tubules under the influence of aldosterone. And then here's the critical event. Is there ADH or is there no ADH? If there's no antidiuretic hormone, then as we go down the collecting ducts, they are not absorbing fluid into the hypertonic interstitial medulla, and so we have a lot of urine that is being produced. When we have antidiuretic hormone, we have the same mechanism going through the tubules all the way through the distal tubules, but when our urine filtrate is getting ready to leave and go down the collecting ducts, now the collecting ducts, in the presence of antidiuretic hormone, are permeable to water. So now when the fluid goes down through the hypertonic interstitial medulla, the water goes into the medulla, and consequently we produce very little urine. And that would make a maximally concentrated urine. And what we're doing also is bringing fluid back into the bloodstream, so we are diluting the fluid in our serum. And how the way this affects us from all these clinical circumstances is because the body senses the low volume of fluids because of diarrhea or because of sequestration or because of peritonitis and an effusion in a body cavity, the body detects that fluid loss. It's fluid loss from, maybe not from the body in the case of an effusion, but it's fluid loss from the extracellular space in the bloodstream. And because of that, the body senses that, and it sort of overrides the fact that the sodium is not low. And antidiuretic hormone is produced in response to the fluid loss. And when that is produced in response to the fluid loss, then the fluid is actually returned to the bloodstream to increase that volume, which is detected. The volume depletion is detected, and so you have now diluted your sodium. So it's not a sodium loss phenomenon, it's a fluid loss phenomenon with an ADH production that allows the sodium to be diluted in the serum when you've lost fluids that contain less sodium than the blood contains. Very common mechanism. Well, as I said before, antidiuretic hormone can be produced in an inappropriate manner. And there's a syndrome, of course, to fit this phenomenon, to explain all those reasons all these cases that we can't explain otherwise. And there's a syndrome of inappropriate antidiuretic hormone release. And the features of that syndrome is that you have hyponatremia and a low serum osmolality. Your fractional excretion of sodium is increased, even though you have a low sodium in your serum. You don't have evidence of volume depletion. And in other words, there is no diarrhea, there's no vomiting, there's no cause for the animal to produce antidiuretic hormone. Your osmolality in your urine is greater than it should be because there's antidiuretic hormone being produced. You can assure yourself that your renal and adrenal function is normal. And if you restrict fluids from these animals, they get better. So that basically is the syndrome of inappropriate ADH. It's very uncommon. but it is a means of the animal having a low sodium without any of the other abnormalities that we've talked about so far. Okay, remember this case? This was our first case. We've just added a few more laboratory abnormalities. This is that 3-month-old Great Dane that was azotemic disproportionately, and we said that that was because of the blood in the bloody diarrhea that it had. Its bicarb is low at 12.1, and it has a very low sodium and a very high potassium. Now, we've just gone through a list of causes of hyponatremia. What is going to be the cause in this case? What's the most common? What's that thing I kept harping on? What's that real common cause? You got to know what percentage play is. It's going to be one of those ADH things, right? One of those third space things. So you look clinically. Now, see, we don't have the benefit of seeing the dog, but so what did he have? Did he have any clinical reason that he could have had like fluid loss and volume, and ADH? Yeah, sure. He had bloody diarrhea. So he had bloody diarrhea. So yeah, percentage play would be that. Sure enough, this dog probably has one of those third space things where he loses fluids, the ADH is produced, and his sodium goes down. At least clinically, it would fit. We don't know that that's really the cause, but it would fit. But he also has a real high potassium. I mean, that's very high. 5.5 is probably the high limit of normal in most laboratories. So that's real high. Why would he have such a high potassium? Right. I mean, from here you can't hear anything, but there was. Well, we have a lot of rule-outs for high potassium. Well, we got to pick one. Okay, that's a good point. Acidosis happens to be the first one on our list of hyperkalemia, and they say, those books say that in dogs and cats, acidosis is not a real common cause of hyperkalemia. Well, that's true because most causes of acidosis in dogs or cats have to do with kidneys, have to do with prerenal and renal azotemias. But when you have acidosis caused by bicarb loss rather than an organic acid excess, that is a mechanism of hyperkalemia. Well, what's the mechanism of that? Why do they say that? Well, the reason is that if you are acidotic, then you have hydrogen ions in excess. The hydrogen ions go into the cells, and to balance things out, the potassium come out of the cells and into the bloodstream. And that's the mechanism of hyperkalemia and acidosis. Well, if you have acidosis where there's an acid accumulating that has its own salt, lactic acid, say, for instance, then you don't have this problem with electrolyte disturbance. When the hydrogen ions go into the cells, they can bring their salt with them, so they're balanced out. You don't have to have potassium come out of the cells to balance the ion problem. So that's the mechanism, or at least that's the reason people say that small animals don't get hyperkalemia too much from acidosis, because most of the time when we're dealing with acidosis in small animals, it's because the animals have renal disease or prerenal azotemia of some cause. But that isn't the case in this particular dog. This dog has bloody diarrhea. This dog is losing, particularly when we're talking about puppies and calves. When they have diarrhea, their whole GI tract is involved generally. So they're losing bicarb all the way from the upper GI tract right out the feces. So this is truly a bicarb loss phenomenon. We do know this animal is somewhat azotemic. Remember that he has a creatinine of 2.1. So there is an element of prerenal azotemia in this animal that would go into this lactic acid business that wouldn't account for the acidosis causing hyperkalemia. But the majority of this dog's acidosis is from a bicarb loss. So yeah, that's a real good reason for this animal to be hyperkalemic. Well, what about hypoadrenocorticism? This dog has a low sodium, has a sodium of 110 and a potassium of 7.9. Does this dog have hypoadrenocorticism? Yeah, sure, he could have hypoadrenocorticism. There's nothing that says he doesn't. Some people use these formulas, which are useless, of sodium-potassium ratio to say whether or not a dog has hypoadrenocorticism. Well, you're better off to figure out what's wrong with the dog than to use a mathematical formula to decide whether they've got hypoadrenocorticism. Because if you use that formula on this dog, he's got it. But he doesn't have hypoadrenocorticism. What he has is a low sodium and high potassium. And as we've already explained, we've got a reason for that. His sodium can be low because of that ADH secretion because of the fluid loss. And his potassium is high because he's acidotic. And this is one of the causes of so-called pseudo-hypoadrenocorticism. Diarrhea in small animals causes so-called pseudo-hypoadrenocorticism. And what that means is people who have observed this phenomenon of low sodium, high potassium, who have used that formula and been confused, have then concluded that we have to learn causes of pseudo-hypoadrenocorticism when actually, basically, you would never have gotten confused if you didn't use the formula to begin with. And we have a low sodium and high potassium, and we've explained it by acidosis in association with hyperkalemia. Well, there are other causes of hyperkalemia, but I think we've explained it sufficiently in this particular dog, and let's look at them. Urinary obstruction, particularly in cats, is a cause of hyperkalemia. And it's one of the few causes that's renal in origin that accounts for hyperkalemia in small animals. Anuric renal failure, which is relatively uncommon, is a cause of hyperkalemia in small animals. I've read, but never seen, massive muscle necrosis that can account for hyperkalemia in many species. Again, we have some examples of this, more so in cows, where we have downer cows. But I've yet to see an animal with massive muscle enzyme elevation that has hyperkalemia. There's a mechanism that's a little hard to understand called the extracellular fluid hypertonicity, in which you actually have something like, for instance, if you give mannitol to an animal, this is an example in which you may actually drag potassium out of the cells. Again, it's very unusual circumstance, but that's called solvent drag and is the cause of hyperkalemia. And certainly some drugs can cause hyperkalemia. Drugs that contain potassium, of course, and then some non-steroidal anti-inflammatory drugs can cause it too. Okay. There are some pseudo-causes of hyperkalemia, some of which are kind of important. Remember that potassium is primarily an intracellular ion. So when we talk about the serum, we have to think about what happened to that serum prior to our evaluation of it. So if this animal, for instance, has a very high white blood cell count, and those white blood cells, or those platelets, more likely, if it's very, very high, those platelets, when they actually are involved in the formation of a clot, when you get the serum, they can release their intracellular constituents into the serum and consequently cause hyperkalemia in the serum that does not exist in the animal. So that's a cause of hyperkalemia. And then there's, remember red blood cells in dogs and cats and horses and cows, they're all kind of different in terms of their content of potassium. And if you deal with human specimens, you're pretty much alerted to the fact that hemolysis in human red blood cells will cause hyperkalemia. Does it cause that in dogs? If you have a hemolyzed sample in a dog, will the sample be hyperkalemic? No, it won't. Because dogs have potassium content within their red cells that is similar to plasma. There's an exception, of course, to that. And that exception is Akitas. Most Akitas have high potassium red cells. So if you have a hemolyzed Akita blood, it will be the serum will be hyperkalemic, even though the dog is not. The other exception would be very young red cells. If you have a lot of reticulocytes in the peripheral blood, then, and then you have hemolysis, then you have hyperkalemia in the serum. Again, this does not reflect hyperkalemia in the animal. It's just an artifact of the serum from the actual. Now, if you recall, we were reviewing the causes of hyperkalemia, and what had started us into this discussion was that puppy it was hyponatremic and hyperkalemic, and we said in that case it was due to acidosis, which in this case was the result of bicarbonate loss through the diarrhea. And then we mentioned the other causes of hyperkalemia, including so-called pseudo-hyperkalemia, and this is not to be totally dismissed in that we frequently will see causes of pseudo-hyperkalemia, more so in species other than dogs, and because in dogs and cats, if you hemolyze the red cells in dogs and cats, you will not significantly influence the serum values of potassium, because the intracellular contents of potassium in dogs and cats' red cells is low or equal to serum rather than a high like it is in humans. That's not the case in horses and in certain cows and in certain sheep. In sheep, for instance, it's known that there are strains of high potassium and low potassium sheep. That's in reference to their red cell content of potassium. In cows, they have sort of an intermediate value for potassium between, say, dogs and horses horses have a high level of red cell potassium, sort of like humans do, so that if you hemolyze horse blood, you will get hyperkalemia. You hemolyze dog blood, you won't, unless it's an Akita, or an animal with a tremendous number of reticulocytes. And if you hemolyze cow blood, you may or may not. Most of the time you do not. Cow blood doesn't hemolyze as readily as dog blood does, so you don't have to actually contend with hemolysis in the laboratory on cows like you do in dogs. The other reason might be that cow blood is not lipemic like dog blood, and lipemia enhances the chances for hemolysis due to changes of the red cell membrane. And since we see lipemia a lot in dogs, then we do see the hemolysis effect. You don't often see hyperkalemia due to thrombocytosis unless you're dealing with animals with actually malignancies of the megakaryocytic cell line, in which you get platelet counts of well over several million. Then you may have the hyperkalemia in the serum. So here we have a 3-year-old castrated male cat who is azotemic, and this is phosphorus again. It is azotemic, very azotemic. We look at that creat. Bicarb is in the normal range, but on the low side. Calcium is low, but the albumin is normal, although we're not talking about that at the moment in terms of hypercalcemia. I put the albumin on because you do know that we're measuring total calcium, and if the albumin was low, then the calcium would potentially be falsely low due to the low albumin, but here that's not the case. And the sodium is in the normal range, potassium is quite high at 7.2, and chloride is in the low normal range. So of the causes of hyperkalemia, what is this likely to be? Now, I've totally left off the clinical picture, which would be very obvious in this instance as to what the problem is. So that this is more an exercise in trying to determine what is the cause of hyperkalemia just from looking at laboratory work, and I'll fill you in on the history in a moment. So remember we said that acidosis is not really common in dogs and cats acidosis causing hyperkalemia unless it's bicarb loss. But then there were some other exceptions to that in which acidosis associated with certain disease processes might be associated with hyperkalemia. What were they? The hypocalcemia is part of this syndrome too. So suppose I tell you this cat is a typical blocked cat. In other words, has urinary obstruction. Remember that urinary obstruction is a cause of hyperkalemia, and we frequently see that in cats, and total anuric renal failure is, which we don't see real commonly. And so this is a cat that is obstructed. Now, this isn't the most dramatic example. I've seen, I guess my record example for a cat with a hyperkalemia due to urinary obstruction is 11.5 for potassium. And in that, there is an association of hypocalcemia with urinary obstruction in cats. And the mechanism of that is totally obtuse to me. And I've asked several renal physiologists about that and some internal medicine clinicians. And I know I asked a couple of very famous ones who said, oh, they are hypocalcemic, but yeah, they are, and it's very transient. And I think that the reason is that often you aren't in the situation where where you actually draw blood on these animals. Obviously, these are treated frequently in practice. The animals the condition is quite obviously diagnosed from a clinical perspective. The animals are treated. The blood is never drawn often. And so often the clinician might wonder why these animals die. Well, if their potassium goes up to 11 or so, you can understand why they might die. And yet many of them recover. The animals that I've seen with potassiums of 11 have recovered. These were taken at an intensive care unit. That's how come we have the potassium values on them. And the animals, the lowest I've seen, I think, has been 2.5 for a calcium, total calcium, and a potassium of 11.5. The calcium returned to normal within 1 day, and the potassium was normal within 1 day. So with fluids, with lactated ringer type fluids. And I don't know the mechanism of the hypocalcemia. They are not clinical for it, so I don't know where it must all be ionized calcium, because there's it's hard to understand how calcium could go that low with no clinical findings, but it's very transient, and I've never seen it even addressed in the literature. But hyperkalemia is quite profound in block cats. Here we have a 2-year-old spayed female St. Bernard, and this animal is, well, I'll leave off the clinical history for now. We're azotemic. We have a low sodium, so you automatically start chinking off those things. Oh, why is it low? High potassium. We'll skip over here. We have a normal calcium, phosphorus, glucose, chloride's low. And we have a urine-specific gravity that's not maximally concentrated. It's not real dilute, but it's not maximally concentrated. So how are we going to sort this out? What I would do is focus on the thing that's most unusual. Yeah, you could focus on the azotemia, but gosh, there's a big list of rule-outs for that. So let's focus on the electrolytes, because they're the most unusual. So we have a low sodium and a high potassium. We have a whole list of things that cause a low sodium and a whole list of things that causes a high potassium. Where are we going to go from here? From a clinical standpoint, in other words, what are we going to rule out first? And I'm keeping the clinical information actually isn't all that helpful. I'll give it to you. This animal came in and was anorectic, weak, had been vomiting and had some diarrhea, but the vomiting diarrhea was not real profound. So we've got to do something next. What do? We order more tests. We could do that. we did a physical exam and we didn't see anything, so that's it. I suppose we could x-ray too, but there's no reason for that. So I guess we order more tests. What more tests do we want to order? Yeah, okay, somebody wants to order an ACTH stim. Yep, sure enough. This animal doesn't stim at all. So this animal has Hypoadrenocorticism. Let's go back. Yeah, this is not a pseudo-hypoadrenocorticism. And this is, this is sort of the knee-jerk that you're supposed to have, is low sodium, high potassium, is hypoadrenocorticism. I showed you previously an example where that wasn't the case. But indeed, can the 2-year-old dog have hypoadrenocorticism? Can a 2-month-old dog have hypoadrenocorticism? Yeah. Yeah, puppies have hypoadrenocorticism, and a lot of people say, oh, no, it's a puppy. Well, no, it starts sometime. In fact, you can, it's got a, and you will frequently see puppies with hypoadrenocorticism. They have abnormal adrenal glands, and sometimes this dog's only 2. Did it have it since the time it was young? It could have. Think how many times it goes to the veterinarian not feeling quite right, maybe a little bit anorectic, to weak. What's the veterinarian going to give it if the veterinarian doesn't know? You're going to give it steroids, so it's going to feel better for a while. And then it's going to, it'll do all right for a while, and then it'll come back in and see another veterinarian and won't be doing right, and somebody's going to give it steroids, and it'll do better for a while. So some of these animals have that in their history. And yeah, they give it to old Doc so-and-so who gives them a shot of something, he's okay for a while. And so some of these animals will come in a little bit older than a few months, but you will see it in a few-month-old dogs. It isn't high on most people's list of rule-outs in young dogs, but after all, there aren't that many things that cause hyponatremia, particularly in light of the animal that has, let's just say this animal had some diarrhea, but particularly in the puppy that comes in collapse with no diarrhea, no cause for it. There's got to be a cause for a sodium of 113, and if it isn't clinically obvious from a clinical sign, in other words, some loss of fluids with that ADH, kicking in, then there has to be a reason. And one of the more subtle reasons in which you would not see a clinical evidence of it would be hypoadrenocorticism. And it's quite a common disease and underdiagnosed in the young animal because people think it doesn't happen there. And it's primarily a disease of young to middle-aged female dogs. It's more common in females. It's a hereditary disease in standard poodles. I've only seen it a couple times. I don't see a lot of standard poodles, but I have seen a couple of standard poodles with it. And it occurs very infrequently in cats. And there was a real nice review. It's 10 years old now, but I haven't seen another review like this in which a series of cases were reviewed by Pauline Rakish and associates at University of Georgia. And they looked at dogs with hypoadrenocorticism, and they retrospectively and said, gee, I wonder what are we supposed to find clinically and in the laboratory? What are we supposed to find? Do we find what is reported, or do we find other things? And 100% of the dogs in their review, these dogs all were diagnosed by ACTH stim test, by the way, and they were seen at a referral hospital. So again, that's all sort of shading what the kind of patient population you would see. But nonetheless, 100% of the dogs were weak. Most of them were anorectic, and a good deal of them had vomiting and weight loss. Only 23% here had acute cardiovascular collapse, the kind of thing that you might say, oh, that's the way the Addison dog presents. Almost half of them had polyuria, polydipsia, and about a third had diarrhea. Diarrhea is not real uncommon, particularly it seems to me in dogs with Addison's that is associated with the animals being treated for Cushing's disease. That's often a clinical sign that you find. And I don't know the mechanism of that diarrhea. I worked with a clinician who biopsied dogs, just out of curiosity, with hypoadrenocorticism to see if there was anything morphologically, why diarrhea? What is how does that work? We know that the phenomenon affects the adrenal, but how does that cause diarrhea? I don't know, and I've not seen that. But I tell you, on the biopsies, they look totally normal. So I don't know why they have diarrhea. They just do. And in the laboratory, what do we find? Well, the classical thing that we're supposed to find, we find in 3/4 of the cases, hyponatremia and hyperkalemia. A fewer percentage of the animals are either normal on sodium and potassium or low on one or the other. Some animals have the high potassium and low sodium. And what I find of interest is that, of course, a great deal of the animals are azotemic. That's pre-renal azotemia. And I find of interest the calcium values. We do recognize that hypercalcemia is a feature of Addison's disease. And hypocalcemia hasn't, to my knowledge, before this report, was really not stated too much as a finding in Addison's disease. Hypercalcemia has to do with what is theorized but not real definitively proven decreased renal excretion of potassium, and the mechanism of hypocalcemia has not been addressed. But hypercalcemia is often associated, not in this series of patients, but I guess I should say it's often written about in hypoadrenocorticism, but hypocalcemia is hardly ever mentioned. And I think it's of interest that in this case there were a lot more dogs that were hypocalcemic than hypercalcemic. Here we have a 10-year-old castrated male Chesapeake Bay Retriever that had lethargy of several months' duration. Normal appetite, no vomiting, diarrhea, polyuria, polydipsia, and this dog belonged to the veterinary technician in a hospital, which you can see from the plethora of laboratory work is the reason that it was all done. And also the woman was very astute, the owner was very astute, and as you see, this dog has real non-specific clinical signs, lethargy and a voice change, or she thought his bark sounded different. So she brought it into work with her over a series of days, and they did some series of laboratory work. Now, this is like being at a university, all this laboratory work on this dog. So we have the animal is somewhat anemic here. Now, we haven't been talking about the hematology, but we're going to talk about it right now. Now, we have the reason that I was asked about this had to do with the differential here. The white count is really not too dramatically abnormal. We see that if we look at the differential in terms of percentages, we have 40 to 30 to 60% segs and 50 or 40, almost 60% lymphocytes. on serial blood work on this animal. And actually, that's why they asked me to look at the laboratory work, actually. And they were concerned because of this, because of the 50% lymphocytes here. And they wondered if there was the animals getting chronic lymphocytic leukemia or something. And then if you look, you really shouldn't look at percentages. Differentials in terms of percentages are just misleading almost. But you always have to calculate them out, and it gives you a much better perspective of what is going on. So here, if we look at the absolute values, everything's the same in the first two rows. But if we look at the absolute values, we see that the segs are borderline on the low end of normal. And here they're actually low. We have 4,000, 4,000, 2,600, 4,000. So here on this particular day, they're actually low. Lymphocyte count in a dog goes to about 5,500. And here we have, it's up at the high end. Here it's well in the middle. Here it's kind of on the high end, and here it's low. And the monocytes, if you just are thinking about dog and cat blood, and you want to look at a blood smear, and you're trying to decide if it's dog or cat, and you can't figure out the size or the red cells, and you can't see the EOs, just the percentage of cells tells you. In a cat, there's more lymphs than dogs. In a dog, there's always monos, virtually. In a cat, there's maybe monos, plus or minus. And the percentage of segs is about the same. But here's a dog that is pushing the lower limit on some of the segs, pushing the higher limit for an adult dog on lymphs. The monocytes are barely there, 150, 150. EOs are kind of always there, which EOs are plus or minus depending on where you live. 190, 390, 370. For an area, this was in New England, for an area in New England, that's a fair number of EOs. This is sort of an unusual differential, and why is that? We haven't been talking about this, but if we think about differentials and what happens to them, there aren't a whole lot of things that white cells can do. They go up or they go down, and that's, makes clinical pathology kind of easy. They stay the same. There's only three things, up, down, and same. And so here we have some that are kind of up. We have segs that are kind of segs that are kind of low, and lymphs that are kind of up, and monos that are low. But most of the time when we think about inflammatory disease processes, we're talking about neutrophilic leukocytosis and a monocytosis. That's a classic chronic inflammatory disease process. Or if we think about neutrophilic leukocytosis, monocytosis, and lymphopenia, that's steroids, isn't it, in a dog? And that's pretty common. You give a dog steroids, that's what you get. Well, isn't this an upside down one? This one's pushing lymphocytosis. It's got very few segs, and the monos are low, and the EOs are always there. It's upside down. It's the opposite the way that steroids affect the white count. And how in the world do we relate this back to this dog's problem? The dog has very nonspecific signs, but it does have voice change. Now, how many dogs with voice change have you ever heard about? It's a very unusual clinical sign. And I know this sounds far-fetched, but it fits. I suggested on the basis of this upside-down white count that they do an ACTH stim. Yeah, and it was low. So this dog has hypoadrenocorticism, and it's more manifest on the corticosteroid sides, or the cortisone aspect, than the mineralocorticoids, as manifest here. The biochemical abnormalities, the biochemical values in this dog were normal. How does that fit in with voice change? Well, what's around the larynx? The thyroid is around the larynx. And there's a syndrome in humans that I've seen, you certainly have probably seen histologically in dogs, in which you have lymphoplasmacytic infiltrate of the adrenal and the thyroid. It's called Schmitz Syndrome. And it's supposed to be an immune-mediated reaction against endocrine organs. And if you have inflammation of the thyroid, you're very likely to affect the larynx. So if you diagnose hypoadrenocorticism in a dog with a voice change, that dog probably has Schmitz syndrome, which indeed this dog had. And if they had been sort of the regular run-of-the-mill veterinarian, they probably would have given this dog steroids long ago, and he would have cured him, but they had to diagnose it first, and so they indeed diagnosed a case of hypoadrenocorticism, Schmitz syndrome in a dog, and it was totally cured with just prednisone. So much for that. Now, most people wouldn't have gone to all that diagnostic effort. They probably just would have given the dog steroids, but being a very good, astute practitioner, they diagnosed it. And I think, is that the end of that one cassette? I think I'm on the next one, I believe. Is that right? I think. Oh, no, I'm not. I'm sorry. This is our next case. It's a 2-year-old castrated male cat. And the clinical signs are lethargy and anorexia, and that's it. I'm not hiding any back from you. And the laboratory abnormalities of interest here are a calcium of 18.6. I like high calciums and low calciums because there aren't many rule-outs. So we got to put our rule-outs in somewhat of a priority order in which is likely, like you would do clinically. You would do the test that's the next test or the next thing you would think about would be the one most likely, not the one least likely. But so let's talk about hypercalcemia in cats, for instance. What are the causes? Why are we going to get hypercalcemia? I'm sorry, what? Neoplasia. Probably should be on the top of your list for dogs and cats for hypercalcemia. The trouble is that it's different. The neoplasm you put top of your list for dogs and cats would be different. For dogs, it would be what? Sure, malignant lymphoma, lymphosarcoma. That would be the most common cause of hypercalcemia, and there it's an osteoclast activating factor is the mechanism. But in cats, it's not lymphoma. What is it in cats? What would you put in cats? It's more difficult in cats. Parathyroid gland tumor would probably be more common. 2-year-old cat would be unusual, but let's just put it in there anyway. And in dogs, where would we go from there? We'd go tumor first, no question. Malignant lymphoma by far is the most common in dogs. And then African gland tumors of the anal sac in dogs. Parathyroid tumors, dogs or cats, but it would be way up there in cats because cats with malignant lymphoma can be hypercalcemic, but it isn't the percentage play. It would probably, if it's going to be a tumor in a cat, it's probably this tumor, a parathyroid tumor. And then metastatic tumors to bone, yeah, they can be hypercalcemic with that. It's something that you will see. Renal failure, it's not highly unusual, not necessarily cats, but dogs. Vitamin D intoxication, particularly when we're talking in small animals, rat poison. In large animals, we talk about plants frequently. Remember we said hypoadrenocorticism, Addison's disease, is a cause of hypercalcemia. Then granulomatous inflammation is an interesting cause of hypercalcemia. The mechanism is supposed to be calcitriol production by macrophages. The remainder of these are pretty unusual. Hyperproteinemia, osteomyelitis, immobilization, that's a human, definitely a human one. Severe hypothermia. And then exclusively in humans, thyrotoxicosis, hypervitaminosis A, and pheochromocytomas. But I would say on this list, from hyperproteinemia on down, is pretty darn rare. You bet for the 90-something, maybe 99% of your cases are going to be at the top of that list. So let's go back to our case. This 2-year-old cat was given fluids, and the following day, or about 14 hours later, calcium was 16.5. Then it was continued on with fluids and Lasix, and after 36 hours, the calcium was 13.6, and 48 hours, the calcium was normal. So it's not likely to be tumor, is it? Because we didn't take any tumor out. So what is it likely to be? Yeah, sure. This one's a rat poison. This is a cat that got into vitamin D containing rat poison. And as you see, cats are, I don't know if cats are just smarter than dogs and they don't eat as much of that or what, but the cats respond pretty well. Whereas the dogs with it, I don't know if it's the intake or susceptibility of the species, but dogs frequently have a hard time, and if you don't, of course, get the calcium down, they will get nephrocalcinosis and die in renal failure. But in cats, of the cases I've seen, most of them have been brought back to normal by fluid therapy. Fluid Lasix, sometimes calcitonin. Here we have this 9-month-old dog. This should look familiar to you. See if you remember this dog. This is the 9-month-old Sheltie, the one that came into the emergency clinic, was given fluids, etc. This was on entry to the emergency clinic. This was the dog with azotemia, and we didn't focus in on the hypercalcemia at that point. But if you recall correctly, this is the dog that got fluids and then was seen by the regular veterinarian, and it was more azotemic than it was before. Remember that one? And what was the diagnosis in that one? I don't know. Diagnosis in that one was renal disease. Remember that? And yeah, there is an association, particularly in young dogs, of hypercalcemia with renal failure. Exactly why young dogs is not entirely certain, but most of the dogs in which hypercalcemia is associated with renal failure, it's in young dogs. But calcium can go both up and down in renal failure. Hypocalcemia is usually not seen. It's usually supposedly very transient and is the result of decreased GFR, which increases the phosphorus and reflexly decreases the calcium, or because you have decreased renal vitamin D and decreased calcium absorption. That's the mechanism if you have hypocalcemia. Hypercalcemia is the mechanism is also somewhat convoluted, in which you have parathyroid hormone stimulated by the decreased calcium that I just talked about and increased phosphorus, and you stimulate the parathyroid so much that you have parathyroid hyperplasia, and then what they call tertiary parathyroid hyperparathyroidism as a result of a lack of feedback inhibition for some reason of the parathyroid, and then you get resultant hypercalcemia. And as I say, you'll notice that most dogs that have azotemia and hypercalcemia are young dogs with congenital renal disease or renal dysplasia. It's hard, it's difficult to find it in older dogs with renal failure, but you do see it. Here's a 1.5-year-old Cocker Spaniel, and this should look familiar to you too, who is azotemic, hypercalcemic, has a low sodium, high potassium, and I gave the albumin here so that you have a perspective on the calcium. And remember the diagnosis on this one? Yep, you're right. This is a hypoadrenocorticism. And remember we said that when we looked at that review of hypoadrenocorticism, that 13% of those dogs in that review were hypercalcemic, 30% were hypocalcemic. And this dog had the expected low specific gravity of the urine because of the low sodium, and had the ACTH stimulation that diagnosed the disease as hypoadrenocorticism. And the hypercalcemia in hypoadrenocorticism, as you would expect, has been more evaluated in humans, and it does correlate with the severity of the disease in humans. The hypercalcemia may develop without abnormal sodium potassium, and those cases are sort of fun because then you get to come to that conclusion just by going through your rule-out list, which isn't very long for hypercalcemia, and you finally get to hypoadrenocorticism and rule it out on that basis by doing testing for it, because it's one of the causes of hypercalcemia. There's supposed to be increased tubular reabsorption of calcium. Experimentally, there's been some evidence of that in dogs, and there's evidence in humans, natural cases. And here we have a 1-year-old shepherd cross dog. The only abnormalities on the whole serum biochemical profile are here. The calcium is 13.7, phosphorus 5.3, and an albumin of 2.2. So do you know about, I should mention that when we're measuring calcium, we are measuring total calcium. And if you want to correct for the fact that you're also measuring protein bound, you can use a formula where you look at the albumin. What I do is say normal albumin is 3.5, and this albumin is 2.2. So what's the difference between 3.5 and 2.2? What is it, 1.3? So you have to add 1.3 onto this, because this is falsely low, actually, believe it or not. So you have to add the difference between this and normal albumin onto this calcium to get it to be what it should be. So this calcium is even higher than what it thinks here, and that's why I'm giving you the albumin, so that you know that we're not falsely increased because of a high albumin, or falsely, obviously it is falsely decreased because of a low albumin. So this dog is lethargic, anorectic, and I think that was all the clinical signs we had. And this was the only biochemical profile. On the physical exam, they noticed that he had harsh lung sounds. So what have we got here? The dog is not azotemic. He's only 1-year-old. He probably doesn't have tumor. So tumor was the big rule out, right? That's the primary thing you rule out. It could be lymphoma. It could be. In fact, they looked for lymphoma in this dog, but let's just say we ruled it out, which we did. So it's not lymphoma, but that would have been the correct thing to look for even in a 1-year-old dog, but it's less likely because of the age. So what else? What is it going to be? It's not azotemia, it's not renal failure. Blasto, good choice. Blastomyces Titer was positive. This dog was from an endemic area with blastomyces, so it was very high on the list of rule-outs for the clinician. Because of the harsh lung sounds, they had radiographed the dog, so they had the pulmonary lesions that were suspicious. So they had gotten to this bottom line a little bit easier probably than we just got to it, but it just goes to show you that sure enough, you're going to find the cause of that hypercalcemia if you look for it, because it's not going to be an aberrant finding. It's a very unusual finding that will have a definitive cause that you will find either clinically or by other tests. And here we had a dog with pulmonary blastomycosis, and they got to that diagnosis primarily through the fact that they radiographed the dog, saw the lesions, and ran the titer. Positive titers mean previous or current infection with blastomyces. Negative titers do not mean the dog does not rule it out at all. Many dogs are anergic with blastomyces and have disseminated blastomycosis with no titer whatsoever. That's true in humans too. That might be the last one. No, the mechanism of granulomatous inflammation and hypercalcemia is that histiocytes in the granulomas produce calcitriol and are responsible for the high calcium, and has primarily been associated with blastomyces in dogs, but clearly other causes of granulomatous inflammation could result in hypercalcemia. Here's a cat that is azotemic, normal phosphorus. A calcium is 17, and sodium potassium chloride is not too bad. Bicarb is okay. So basically we're focusing in on azotemia and hypercalcemia, but we're going to rule in the specific cause, we really need to focus on the most unusual result, the calcium. So where are we going to go with this cat? Well, they went somewhere with this cat. And this was the next day. Calcium is 7.7, and BU and creatinine he's more azotemic actually. Now the potassium is a little bit lower. What happened to this cat? 24 hours later, this is what this cat's like. I might have been 48. What's that? Probably, yeah, it probably did get fluids, but it's like we saw with that cat with the rodenticide toxicosis, it does take a while to get those calciums down with that. In this particular instance, this cat went to surgery. This cat is a cat with a parathyroid tumor, and parathyroid adenomas are not real unusual in older cats. And this cat, actually the youngest cat I've seen with it is about 3, so it isn't necessarily real old cats. And the half-life of parathyroid hormone is very short, minutes we're talking about, so it doesn't take long at all. They can be waking up from anesthesia and be hypocalcemic. That certainly is seen to be the case if they've ever, for instance, taken out parathyroids inadvertently with thyroids in cats, and if you whip them all out, they might be hypocalcemic when they wake up from surgery. Otherwise, the hypocalcemia may ensue a little bit later. Depends on how many parathyroids you damage. But this one was a parathyroid tumor, and it was taken out, and hence the calcium plummets. Yeah, I thought, okay. Okay. So now we're still on the dog and cat thing, so don't get excited yet. But again, this is one of those diseases that we find a little bit easier to handle in another species, and here's a cow, a 5-year-old Holstein, and the total calcium here is 1.8. That's not ionized or anything, that's total. And you see the normal is 7.9 to 10.5, so that's low. The phosphorus is low at 1.2, and the CK and AST are high. Now we'll talk about that later, but here we're talking about calcium, remember. So here we have a cow with what cow disease? Yeah, that's that other cow disease. It's milk fever. This is Proterium, Paresis, and Hypocalcemia. So if we're talking about hypocalcemia, I always kind of remember that, because all you got to know really is the physiology of one good species, and you can correlate it to many species. And when we're ruling out causes of hypocalcemia, I always think about that because that's one of the rule outs. We think about milk fever, but what would it be in a dog or cat? Would it be pregnancy toxemia? It could be pregnancy toxemia in a horse as well, hypocalcemia in late-term pregnancy right after parturition. Hypoproteinemia is really a fake cause of hypocalcemia. It's the effect of measuring total protein, total calcium, in which you're measuring protein-bound and non-protein-bound calcium. Hypoparathyroidism isn't as rare as you might think. Hypoparathyroidism occurs with not great frequency in dogs, but it is a cause of an isolated hypocalcemia with no other apparent cause. It also can be an effect of surgery when you're taking out thyroid lobes, although most experienced veterinarians are not removing all the parathyroids with the thyroid lobes in cats. It also can be a toxic effect or secondary to inflammation or partial damage of the parathyroids at the time of surgery. So that sometimes people will take out a parathyroid, say adenoma, and because of the surgery, the parathyroid adenoma, they may damage the blood supply to other parathyroids, and later on when they infarct, the animal becomes hypocalcemic. So that's a cause of hypocalcemia, and you can see that here. Pancreatitis is not real uncommon cause of hypocalcemia, and it may be the only sign of pancreatitis in cats. Most enzymes are useless in cats in determining if the animal has pancreatitis. In fact, if anything, they may go, for instance, lipase may go down in cats with pancreatitis, which doesn't make any sense. So basically, amylase lipase enzymes are not useful in cats for the diagnosis of pancreatitis. Many cases, as you know, histologically that you've seen have no clinical correlate. If they do have a laboratory abnormality, you might look for hypocalcemia in cats with pancreatitis because that might be the only finding. Antifreeze poisoning, ethylene glycol toxicosis is not an unusual cause of hypocalcemia in dogs and cats, and the mechanism is to the formation of calcium oxalate crystals and precipitation in the kidney. So we do have hypocalcemia is sometimes the presenting sign in those animals where they have clinical evidence of hypocalcemia with trembling and shaking, and they will, of course, be severely azotemic. Phosphate enemas, if given to small animals, including cats and small dogs, will induce a profound hypocalcemia and hyperphosphatemia. As I mentioned before, urinary obstruction in cats, you won't find that in the book. I couldn't find anything about it in the book. But it does happen, and it's very transient. Obviously, if you give calcium chelating agents, I always thought that's cheating. I think people like to make their lists long. So you give a EDTA, yeah, it makes them hypocalcemic. I tried to look this one up. I saw this in a list and put it in my list. That's how things get in lists. You know, you make up a list and you look in a book and you find a list and you say, oh, I'll put that in my list. But I saw this. This is in Duncan and Prossy as one of the causes. I meant to ask them, too, where that came from. They referenced it. Alkalosis was associated with hypocalcemia in ruminants, and I finally went back to several references that referred to, and it was a reference to experimental evidence of experimental reproduction of abomasal atony in sheep, and they were hypocalcemic and alkalotic. And I thought, yeah, but so there are two different mechanisms. The two conditions, alkalosis and hypocalcemia, are quite common in ruminants, but I doubt that they actually are really related to one another in mechanistically. At least I didn't see any evidence of that. So it's on my list too, but I don't believe it. Intestinal malabsorption is reportedly a cause of hypocalcemia, not one that I've seen, but I've seen reported. C-cell tumors of the thyroid is a real reasonable reason for hypocalcemia, but it's very, very rare. C-cell tumors are very unusual in dogs. This is one of my favorite. It's my favorite because it's so bizarre. Blister beetle poisoning in horses. I remember it because it's one of those things to throw out and make people think that you really know a lot. But the mechanism of that is really hypothesized. It's a series of cases of blister beetle poisoning in horses. It was noted that the horses were hypocalcemic, and it wasn't just slightly. They were hypocalcemic, and it was conjecture. Well, the conjecture was that they had increased calcium excretion in their kidney, which would have been my conjecture too, but I thought it was interesting that it was an official, theory that they lost calcium in their kidney, which was reasonable. Where else would they lose it? I think it's always fun. It's like, what do you think the mechanism is? Well, the mechanism is they're losing it. And then this was a bizarre one. There was a case of salicylate toxicosis in a cat, and in which they gave bicarbonate, and the cat became very hypocalcemic. And then finally, pseudo-hypoparathyroidism, which is a human condition associated with mental retardation, is a cause of hypocalcemia. But anyway, that's my list of hypocalcemia. I'd like to scratch this one off, but I'm not remaking the slide. Here's a 2-year-old cat we aren't covering liver enzymes today, but the liver enzymes are elevated in terms of the leakage enzymes here. Alk phos is normal, bilirubin is high, and protein, albumin is on the low side, and the calcium is 7. Now this one should be kind of obvious what point I'm trying to make. It's we have hypocalcemia in a cat, high liver enzymes. What could it be? Yeah, sure. This is what I'm talking about. This cat has pancreatitis and was proven to have pancreatitis, unfortunately, at autopsy soon thereafter. But, and that's usually where you diagnose pancreatitis in cats, actually, is at autopsy. But this one actually had hypocalcemia, and in retrospect, looking at the laboratory work, it at least should have been in their differential as a potential cause. Here's an 8-year-old dachshund who is very severely hypocalcemic, has a calcium of 4. And really, what else is going on here? Not a lot. Normal electrolytes otherwise, and not azotemic. In fact, the creatinine is really kind of low. Hypocalcemia, nothing else going on in a dog. What test do we do next? What's that? It's not renal failure. Well, these people were pretty smart. They did a parathyroid hormone assay, because what we have and what's typical of these is these animals don't have any other laboratory abnormalities. They have persistent hypocalcemia. They're usually clinical for it, and often by the time they're measured, by the time they come into the veterinarian, their calcium is quite low. But it's because it's becoming low over a period of time, and they've gotten used to this low calcium, so they aren't presenting to you until the calcium is not just a little bit out of the normal range, but really out of the normal range. And the parathyroid hormone value is very low. So this animal is an animal with hypoparathyroidism. And these animals have to be supplemented with vitamin D and calcium lifelong because of this problem. But this is not really rare, but not real common either. Here's a cat that presented for weakness, depression, increased heart rate, slow capillary refill time, and pale mucous membranes, and was obstipated. And here we have some really severely abnormal electrolyte values. We have a sodium that's high at 170, a potassium that's high at 6, a calcium that's low at 6, albumin was normal, and a phosphorus of 43. That's kind of high. The animal was mildly azotemic. Well, sure. Okay, we have iatrogenic. Clearly, we haven't talked too much about phosphorus other than it's a measure of GFR. And just like BUN and creatinine, I would focus in on this one. Why? Why? Because there's very few rule-outs for this. And BUN and creatinine and phosphorus are all similar measures of GFR. And just like when the BUN and creatinine are not proportionate to one another, you have to look for other causes than GFR effects for the BUN creatinine abnormality. Similarly, you have to look for other causes than GFR effects for phosphorus abnormalities that are inappropriate for the BUN creat. And the only way you're going to get phosphorus up like that is if you give it somehow. And we see that whatever it is that you gave this animal, we have an effect of a low calcium and high phosphorus. And the most common reason for that is a phosphate enema. And what we see then is hyperphosphatemia, and that's just because you get absorption of the phosphorus from the colon. And of course, this hyperphosphatemia may be exacerbated by any prerenal azotemia that exists, which would increase the phosphorus. And they often become hypernatremic because the phosphate enemas contain sodium as well. And their potassium may be both high or low, depending on the state of acidosis that exists, or what their problem was prior to presentation. Most of these animals are obstipated and are being treated repeatedly with phosphate enemas, although it doesn't take many phosphate enemas to cause this effect in a cat. In a small dog, it might take more than one, but it occurs in both cats and small dogs. Large dogs, it usually doesn't occur in. Is that it for that one? Okay. So I think that we've pretty much covered what I want to cover in small animals, and we're going to proceed. Let's see what time. Yeah. How far have we got till the next break?
About 10 minutes.
Okay. We'll just start very briefly with cows, because I've got quite a lot to cover in cows, and I think cows are pretty exciting in terms of their laboratory work. If you like clinical chemistry, you'll love cows, dairy cows. And we'll start with this, and we'll get going, and then we'll come back and we'll finish out everything with dairy cows. What I want to cover here is a laboratory assessment of the recently fresh cow. And remember, fresh, that means, you know, it has calves. You know, it's recently fresh, that means she recently had babies, in case you haven't been thinking about cows for a while. Why do we do this? We do it because we want to confirm the clinical diagnosis and to rule out concurrent disease problems. And boy, do dairy cows have disease problems, metabolic diseases early on in lactation, because they're under great metabolic stress, and they just, even though we have like great genetics in dairy cows, they just weren't made really to handle the stress, and they're not a normal animal. They're under, they're just walking the borderline of abnormal physiology every day up to peak lactation. So that's why we get into all these, we almost always have more than one problem in a recently fresh dairy cow. And then of course, like with any species, we want to confirm our diagnosis, but more importantly, to determine the prognosis, to know where to go from here in terms of a practical standpoint from the clinical aspect. We'll start with this first case, which is really your case number 2, I believe, which is a 5-year-old cow, Holstein. And she's, well, let's see, she's 4 days fresh, I think. She freshened, 2 days after she freshened, she had milk fever, was treated, got up, and now she's 4 days down the road and she's down. And these are the laboratory abnormalities we have. And I've got, and some of these I've got the reference ranges off to the right, which is helpful. This does not have that cow disease we talked about, so, you know, we're in trouble. You know, we only know 2 cow diseases and we talked about them. So this is not that one with the calcium. And here's the high, we have a high CK and a high AST. Good Lord. What's wrong with her? She's down. Hey, you see, you can tell that. I said she was down. She has the Downer syndrome. What could be easier than that? See, cows are really easy, you know. She's down. They call it the Downer syndrome. You know. What else could they have? Well, what is it? Well, it's a lot of things. It includes an inability to rise from a variety of causes, and those causes include many disease processes, including milk fever, paresis, paralysis or paresis, which is usually from dystocia, septicemias from a variety of sources, usually it's reproductive or mastitis, and a number of metabolic disorders. The laboratory abnormalities that we'll see in a down cow will be primarily a reflection of the diseases that they have, obviously, and will help to detect diseases that otherwise clinically may not be so obvious. The diseases include, as we said, milk fever, which is often the cause of the Downer state, ketosis, displaced abomasum. See, we got other cow diseases here you can put on your list. Displaced abomasum, remember we had these 2. Now you can add ketosis, fatty liver, mastitis, and metritis. All occur in the Downer state. The Downer cows, of course, are frequently hypocalcemic because that's often the cause of why they're down, but they have often an accompanying low magnesium and phosphorus. Low potassiums may occur in Downer cows that have the so-called creeper syndrome, which they can get up and move somewhat, but they can't totally rise. And they, by definition almost, have a high serum AST and CK, and we'll talk about that in a minute. Leukopenia, degenerate left shifts, are often seen with endotoxemia and may be clues to that problem occurring in the Downer syndrome. Let's talk about the muscle enzymes CK and AST, and they're illustrated here as the red and the yellow on this graph. And basically, it's a sort of a stylistic type graph. We're going to ignore the LDH, which is green, which is days following muscle injury. And what you see here is that we're using CK and AST as a way to give some sort of perspective to this one-shot. Basically, what we're looking at when we look at any laboratory work is we're trying to look at a snapshot that really is a reflection of the whole roll of film, the whole videotape. And we're trying to make something which you got to watch what you say about like one point in time. One laboratory result, one point in time, does not necessarily reflect the entire picture. So we're trying to make some sense out of this little snapshot. And we use CK and AST to give us some time perspective on the abnormalities. CK, they're both muscle enzymes, and AST also comes from the liver. But CK is a muscle enzyme alone, and it rises very rapidly so that you're going to get peak values of somewhere between 24 and say 36 hours. We're going to have peak values in CK, and then they go down very rapidly. AST rises more slowly, and here you won't get peak values until 72, 96 hours. You'll get peak values AST. So we can use these two enzymes together to give us an indication of both current muscle damage, muscle necrosis, and past muscle necrosis. And that will help us clinically in making appropriate prognostic claims for the animal. If we go back and look at our Downer cow now, we see what? We see that her CK is very high and her AST is very high. What does that tell us about the time course of this problem? Yeah, what it tells us is that she has current muscle damage and she's had past muscle damage, at least, say, 72 to 96 hours. And if you have a cow that's down, they are subject to what they call the compartment syndrome. And it's virtually a result of the animal's entire body weight being placed on its muscles in the down state. And you compress the venous return from the muscles that have a lot of fascia around them, and you basically result in ischemic necrosis of those muscles. So if the animal is down for whatever reason, let's say she's just down from milk fever, a condition that's totally curative, even if she's down from milk fever, you don't get her up, and even if you correct the metabolic problem, she may never get up again because she has sufficient muscle necrosis from being in the down state that she will not be able to rise. And you can see what's happening here, and that's what's happening in this case. This was not a cow with milk fever. This is a cow that had milk fever, was treated, but basically she had an element of paresis from dystocia, and she went down because of that. She wasn't down in a place that they could move her, and you have to keep these animals slung, and you have to keep moving them, or no matter what the reason was that they were down, they won't get up again. And that was the situation in this cow, in which she wasn't down in a place they could move her, and time passes, and after a while, it's really pointless to even necessarily know the cause. You know this cow isn't getting up again. I'm not saying there's a magic number for CK and AST, but they're certainly combined with the clinical circumstance and what you're seeing clinically, you can make the judgment that this cow is not likely to ever get up again. She won't have muscle tissue to hold her weight up. So this was a cow with a non-metabolic cause of Downer syndrome, and has a magnesium that's in the normal range with other electrolytes that are normal. Looks like we have a different phosphorus here. But it's more common to find them with either a normal magnesium or a low magnesium. And this case here is actually, it's not unusual to find them of this severity, where you have a calcium of 3, high CK and AST, and a very low magnesium, as you see here. Some people say that they should be comatose here because of the magnesium, and certainly there is an effect of magnesium on calcium, such that magnesium is required for some of the enzymes for calcium synthesis and release. And so if you are hypomagnesiemic over a period of time, you will be hypocalcemic. This animal theoretically should not be able to recover from this hypocalcemia unless she's treated with magnesium as well. But generally, most of the milk fever treatments include magnesium. So this is a much more close to the circumstance that we see more frequently, to have a low calcium and a low magnesium plus or minus a low phosphorus. Now here's a case. I think this is one of your cases here of a 6-year-old Holstein, or it's from a blood work like that cow. And this cow freshened in the recent past and is not eating. And I'll leave the rest of the symptoms off the signs off for now. Here we have a blood smear from her, and focus in on the white blood cells. And we'll look more closely at one of them here. What kind of a white blood cell is that? Well, somebody said a band. I think I heard a mono. Well, it is an odd-looking white blood cell, isn't it? If we go back and look here, I'm going to tell you that all of these are in the granulocytic series. And someone suggested band, and that was a good idea because it wasn't totally lobated. And here we have a granulocyte. I was going to say segmented cell, but it's clearly not segmented. It has a round nucleus. And this finding is not unusual at all in cows with inflammation. Cows with inflammation tend to be leukopenic at first. And that's because they frequently are dealing with endotoxemia in cows. And Pellegroid change, or the phenomenon that resembles but is not Pellegroid anomaly, is very common in cows. And that's what this is. And I think that when we look at the laboratory work from the cow in your handout, that actually those bands probably were not bands. That was information from the clinical practice. I didn't see the slide. These are often diagnosed as bands, but a band is really an immature neutrophil that hasn't lobated fully. If you look at the cytoplasm of these cells, and you will see cells just like this cell that have a round nucleus, they have the chromatin aggregation of a mature neutrophil. They have the cytoplasm of a mature neutrophil. The only thing they don't have is the lobation of a mature neutrophil. This is called Pellegroid change, P-E-L-G-E-R-O-I-D. Pellegroid change is the result of usually bacteremia and endotoxemia, but other things can do that, like chemotherapeutic agents, for instance, in which there's a failure to fully lobate of the granulocytic series. And it isn't always just neutrophils. Often the eosinophils are similarly affected. And it's a reflection of generally endotoxemia or bacteremia, and it's real common in cows, such that you may see many so-called segs that have round nuclei. And that's what this is. This is really not a band, although many people, let me tell you, will call it a band, but it doesn't have any immature characteristics. It doesn't have any different color cytoplasm. It has mature cytoplasm. It doesn't have a looseness of the chromatin. It's really a Pellegroid seg. So if we look at your case of this 6-year-old cow that isn't eating, is febrile and has a hot, swollen quarter, we see that she was reported to have 4,500 white cells with 600 segs, and 2,000 bands. I'd be willing to bet that a lot of those bands, if not all of them, are really Pellegroid segs. She also is lymphopenic and has a normal monocyte count. We also have some other biochemical abnormalities from her. Her calcium is normal. She has some enzyme elevations here. Her SDH, or sorbitol dehydrogenase, is high, as is her AST and GGT. What are they? Anybody know? SDH and AST and GGT? Okay, we got liver. Somebody said liver. That's good. Yep, they're liver enzymes. SDH, or sorbitol dehydrogenase, is a liver enzyme in every species. Every common species, I should say, but it is liver specific in dogs and cats and humans and cows and horses, and it does not come from other sources. So it's a useful enzyme that way. Why don't we use it in the other species? Well, we don't use it in the other species because we don't have to. We have ALT, so we don't have to use SDH, but ALT isn't going to work for us in cows, so we use SDH. It's what we call a leakage enzyme, so it's present in the cytosol and will leak into the bloodstream with membrane permeability changes in the cell. AST is very, very similar, except for it's a leakage enzyme in the hepatocytes, but as you know, we've already talked about, it is not liver specific. It comes from muscle too, cardiac and skeletal muscle. GGT is a cholestatic enzyme, gamma-glutamyl transpeptidase, as is alkaline phosphatase. Alkaline phosphatase comes from other sources. GGT, although it can be found in ground-up tissues from other places in the body, the portion of GGT that's in the serum is of liver origin or is cholestatic. So we use SDH and AST as leakage enzymes in cows to indicate liver degeneration or necrosis, and GGT and alkaline phosphatase to indicate cholestasis. We don't use alk-phos so much because of the other sources of alk-phos. Now, if we look at the time course, we can use, to some extent, we use SDH and AST to give us a time course on liver damage, but because of the non-specificity of AST, it doesn't work very well. But SDH rises, is in the green here, and rises more sharply than AST does after liver injury, such that we'll get a peak here, 24 to 36 hours, and AST at more like 72-hour peak. So it is a delayed peak, and it's a little bit more broad on AST. GGT takes quite a bit longer to rise, but remember now, GGT is not telling you the same sorts of things. GGT is cholestatic enzyme, so it's telling you more about the biliary side, whereas this is telling you about hepatocyte damage. So if we go back and now we're looking at this cow that's leukopenic, has a left shift, has some Pellegroid segs or bands, depending on who looked at the slide, and also has these clinical signs and these findings. First of all, what's the source of her leukopenia? Yeah, she's got mastitis. So she's got mastitis. She probably has, let's just say she has E. coli mastitis and is endotoxemic, which is probably the case. What are we going to give her to that may relate to that will cause this problem here? Is it possible that she has a problem that is affecting both her CBC and her biochemical analyses in the same problem, causing both processes? It's unusual, but when we're talking about animals that have had significant bacteremia, we can get secondary liver problems, and the mechanism of that is thought to be primarily due to endotoxin production. And a lot of this is theory, but the observation has been made that animals, and we can talk about cows specifically here, a series of cows were examined and reported upon that had as their primary problem recently after freshening either mastitis or metritis. They also all had some evidence of endotoxemia. They also all had biochemical evidence of liver disease. And these animals, after were all diagnosed with biopsies as having a variety, actually, of liver histologic abnormalities, which varied from necrosis to some element of inflammation and cholestasis. And then basically we got theoretical about, well, what is the mechanism here? And we know that endotoxin can induce cholestasis directly by influencing microtubule function in the liver. So that's very easy to explain and has a real definitive experimental basis. Endotoxin can cause hepatic necrosis that is believed to be mediated through ischemia and does cause decreased hepatic gluconeogenesis. And in all of these instances, these clinical cases that were reported on, the animals all did slowly recover, which is useful information to know because many liver diseases, or in particular fatty liver in cows, the animals would not recover from that. So knowing that there's another option, another rule out for liver enzyme elevation, particularly if it's associated with clinical or biochemical or CBC evidence of endotoxemia that has a better prognosis than fatty liver, is very important. And this cow slowly recovered. Our next case is a 4-year-old cow that had freshened 3 weeks ago and had milk fever, but didn't now, and now she's not eating. And actually this is normal here. Her glucose is low, it's not normal, and her BHBA or beta-hydroxybutyric acid is high in the serum. So ignore the N's here. You can see the normal is 40 to 95, and BHBA is normal up to about 8.8. And a cow-side test, if we looked at her milk and we did a test for ketones here, we'd be positive. What are we measuring in this keto stick? What is that? Yeah, acetoacetate is what we're measuring in the keto stick, whereas in the serum, we're measuring beta-hydroxybutyrate, and those are both ketone bodies. So what are we talking about here? Well, we're talking about a clinical condition that's very common in early lactation, high-producing dairy cows, a condition called ketosis that is basically a disease of negative energy balance. The early lactating cow is under tremendous metabolic stress for milk production, and it just so happens that in early lactation, cows tend not to eat well, and they don't reach full eating capacity until about 3 to 4 weeks since freshening, and they reach, or 6 to 7 weeks, I should say, and they start to reach peak milk production at 3 to 4 weeks. So we clearly have a problem here. We have tremendous energy drain and decreased intake, or not sufficient intake, I should say, and it's just set up to have the clinical condition of ketosis, where fats are mobilized for energy, and there's insufficient glucose to run the Krebs cycle, so we develop ketosis. Ketones can be used for energy, but also in excessive amounts can cause clinical signs. And clinically, it is characterized by the demonstration of these ketones in either the blood, urine, or milk, although clinically it's probably more important to demonstrate them in the milk or blood, since urine levels of ketones are often excreted when the animals do not have elevated levels in the bloodstream. They're often excreted in the urine. The animals also have low glucose and to have the syndrome, have clinical signs attributable to these excessive ketones. Subclinical ketosis is a demonstration of ketones in these various fluids without clinical signs. And what are we measuring? Well, we're measuring primarily acetoacetate and beta-hydroxybutyrate, and the blood levels of BHBA and the milk levels of acetoacetate correlate with clinical ketosis, whereas the urine levels do not correlate as well because of the preferential excretion. Well, 1 week later, after this cow had been appropriately treated with dextrose and propylene glycol, she returns entirely to normal. So this cow had very mild elevation of beta-hydroxybutyrate, very mild clinical signs, and yet clearly was not a normal cow with just an incidental finding of increased ketone levels. This was a cow with a mild case of clinical ketosis, was treated with propylene glycol, dextrose, and was just fine 1 week later. Virtually anything that causes the early lactation cow to not eat is going to make her ketotic. Here we have a cow with a normal calcium, phosphorus, and slightly elevated AST. She's recently fresh within the last 4 weeks. Now here's more like what we usually see in clinical ketosis. We see a cow with a beta-hydroxybutyrate in the hundreds and a glucose of 25. And as the important thing or the important aspect of understanding ketosis in cows is understanding that it's not that all of these disease conditions frequently occur with other disease problems. So the reason for running the biochemical profiles is not necessarily to confirm the diagnosis the clinician has made, but to assess as to whether there are other problems in these animals, which in this particular animal there is not. I'm sure that at the cow side this diagnosis was obvious, either on the basis of testing the milk, but they would be running the profile to assess if something else was also abnormal, which it was not. Here we have a cow with what disease? Sure, it's another cow with milk fever or parturient paresis. And her electrolytes are just about normal, except for her chloride is low. We start to see low sodiums and low chlorides in dairy cows. You think about GI stasis. And we see that she is ketotic as well with a low glucose. So this animal who's going to be treated for milk fever may need to be treated for ketosis as well. Or if you just get her back on feed, that will be fine. So she's got to get up and get eating, or she's going to become progressively ketotic. It may be clinical for that, even though you've treated the hypocalcemia. So you start to have one problem in these early, recently fresh cows. You're going to run into other problems because of their tremendous metabolic stress. So you basically will have to treat multiple problems at one time. Here we have another 5-year-old cow that freshened about 25 days ago, and she has fairly nonspecific signs. She hasn't been real right since she freshened. She's had some problems with retained placenta, and hasn't been eating right for some time, and has these biochemical abnormalities. So we have a high SDH, a high AST, a high GGT, and high BHBA. So this clearly points to what? SDH, AST, GGT. So we have something wrong with her liver. There's no question about that. And she's ketotic. Well, what does that mean? Well, she's probably in peak lactation, or she should be if she wasn't off feed and everything. And this is just probably a reflection of her other problem, not necessarily a primary problem in this cow. So what are we going to do further? What are our options here? She doesn't have any evidence currently of endotoxemia. Her CBC is normal. She's not one of these cows with endotoxin-induced liver problems. We have to do something. And she isn't showing us anything on the clinical. You've done your clinical exam. You're out there. You got this problem. We have to do something. What would we do if it was a dog? Liver biopsy. Hey. Well, these people get, this particular question was a little bit aggressive. So we have a little bit more liver to look at on this one. But liver biopsy is right. That's what you'd go to next. And you all can diagnose this, right? Oh, actually, you all know that was the liver, right? That's the liver. And it's pale yellow and friable. And what diagnosis would we have on that? Sure, this is a fatty liver in a cow. And what is this syndrome anyway? All cows have some fat in their liver, particularly near parturition. And they've shown that this fat accumulates before they freshen. And that the syndrome of fatty liver occurs not like they used to think years ago in just obese cows, but it occurs in both obese and non-obese cows, and seems to be more related to the degree and rapidity of the weight loss than to obesity itself. But obese cows are predisposed to the condition because, because of the mass of adipose tissue, which actually decreases what they can intake into their rumen, and therefore the likelihood of anorexia, which leads to this fat mobilization, which leads to this problem. We talk about fatty liver syndrome in other species, and just like fatty liver syndrome that you see in cats, fatty liver syndrome in cows is particularly important to make the diagnosis because of the prognosis associated with the condition. The clinical signs are that the animals are abnormal since freshening. They usually have problems from day one. With retained placentas, ketosis, environmental mastitis, displaced abomasums, they have a variety of problems. They may actually show neurologic signs, which people attribute to hepatic encephalopathy. But all in all, what we really want to be able to do in these animals from a clinical perspective, other than prevent the disease, would be to make the diagnosis as soon as possible because it correlates with a poor prognosis. Why? Because there's something about these animals that have this severe fatty liver that results in an impaired immunologic response to a variety of disease problems, including inflammation. Apparently, inflammatory response is impaired, and they just do very poorly, and they are usually shipped as soon as the diagnosis is made. Well, then it becomes critical to make the diagnosis. What do you find in these animals biochemically? They have low cholesterols, increased serum non-esterified fatty acids. They're ketotic and hypoglycemic. And if you're lucky, they have increased sorbitol dehydrogenase, GGT, and total bili. That's very unusual to see the whole total bili increase, but you will see it. And there's a problem with each one of these. Well, what's the problem? The problem is that virtually every sick cow has a low cholesterol. So that's totally nonspecific. Any cow that is ketotic, that is hypoglycemic in this sort of fat mobilization stage, is going to have increased serum non-esterified fatty acids. It's a reflection of that fat mobilization. So it's not at all specific. You have an animal with ketosis, she'll have high NEFAs. And the same thing goes for the demonstration of elevated ketone bodies in hypoglycemia. Virtually anything that causes that cow to go off feed in early lactation, which she's in great metabolic stress, is going to cause these laboratory abnormalities. And what about this? These are real specific. SDH and GGT are specific liver enzymes. We could argue that AST comes from muscle. Billy, of course, could come from the red cell side or the liver side. Seldom is elevated in cows, and but if it was, it would be evidence of liver disease. The biggest problem with these is they are not sensitive. Yes, if they're elevated, they will be elevated in severe cases of fatty liver syndrome, but you can have cows with not obvious, but diagnosable fatty liver syndrome that do not have elevations because these are not sensitive enough to detect the abnormality in the liver. So what are we left with? They actually diagnose fatty liver syndrome by biopsy in cows, and what they actually do is not just look at the liver. In fact, they found that sending the liver to a pathologist to have someone evaluate for the amount of fat in the liver cells is non-specific. There's always fat there in the liver of recently fresh cows. And how much is too much? Well, it's very qualitative for the pathologist to say, you know, 2/3 of the liver looks involved, 2/3 of the liver seem to have fatty change, et cetera. Apparently more specific or sensitive for the needs of making the diagnosis are the determination of the buoyancy of the liver biopsy samples in various solutions. And they actually make solutions of copper sulfate and look for buoyancy in 3 different solutions to determine the percentage of fat. If it floats in all 3, there's 35% lipid and 25 and 13%, depending on whether it floats in these various solutions. And that's still used as the means for the sort of definitive diagnosis of the syndrome. And if you can document the animals have this greater than 35% hepatic lipid, you can reasonably give a poor prognosis to these animals, and these animals will be shipped on that basis. They will not be kept in the herd. You will have variable clinical signs in any other of the buoyancy results, so therefore you cannot definitively make the diagnosis based on that with just those results. You would have to have clinical and maybe biochemical evidence to support the diagnosis. So here we have a 3-year-old cow, and I think this one should look familiar to you, that has some electrolyte abnormalities, a low sodium, a low potassium, a low chloride with a high bicarb. And now that we've talked about BHBA, we'll add that in. She's also ketotic. What do we have? I'm leaving the clinical information out. Okay, so you would expect a ping in the, okay. This is a displaced abomasum. And we've talked about the mechanism of this, but in the displaced abomasum, we sequester hydrochloric acid in the abomasum, and we decrease the chloride and increase the bicarb in the serum as a result of that. We get hypokalemia from the 2 mechanisms, alkalosis with driving potassium into the cells, and also because dairy cows intake a great deal of potassium in their feed, if they are totally anorectic, their kidney will still excrete potassium at the high level that it's used to receiving. So it takes 3 days for the kidney to compensate for the low intake of potassium. So consequently, they're hypokalemic from that source. They become hyponatremic from the old fluid sequestration ADH release mechanism and dilutional decrease in sodium. 1 week later, after this animal had surgery for the displaced abomasum, we see that the problem is totally corrected, and the animal is no longer ketotic. Not an unusual problem in recently fresh cows. So here we have one more case, and is this, I think actually this might be the last slide on that, is that right? Okay, so I think this case is actually the last case that I want to present, and this one I'm leaving up to you and to show you the benefits of using the biochemical profile in animals. This shows you why you aren't going to just go out there and treat that cow with this problem, how actually doing the biochemical profile might help you make another diagnosis here. So we have a cow that's recently fresh and she's down. And this is what, we went out and took blood on this cow. Meanwhile, we treated her. But when we got the blood back, we went back out to the farm. So we make one diagnosis here, right? She's what? So she has milk fever, okay. How long has she been down? Not very long, not too long. She's just getting the rise in her AST. Is there anything else wrong with her? Yeah, okay, so here's a down cow with milk fever with a displaced abomasum. I couldn't fit her bicarb on here, but it was high. So this is the benefit of doing it. We have the cow with a number of the common cow problems. They all occur together, and you, believe me, if you tried to hear the pings on these animals, which are, if those of you that practice in cow medicine know what I'm talking about, it's darn hard to hear when that cow's laying down on her side. And so it behooves the veterinarian to make another trip out to the farm to see if they can't hear the displaced abomasum or to see if she had a floating abomasum. And sure enough, they went out, and on this cow she did. And they did surgery on her then. But it would not have been detected, of course, without the use of the biochemical profile on the first exam. And I think that's all I've got for you. So.